Sorry
Thank
to
you.
cut
Thank
short.
you very much.
I
Thank you very
think
much.
Ullas sir has also got a talk next time around. Please stay around, sir. Ashish also.
Yeah, thank you, and it's a great show.
Sir,
Pleasure. Yeah.
I
thank you,
come
sir.
back.
Please stay
I
on.
come back.
Stay you, sir.
Ashish, thank you.
Yeah,
Ashish.
thanks. Great pleasure. Fun.
I request
Doing
Dr.
this.
Casey to take over and steer the next session. Ullah sir is also there, and please carry it forward.
Thank you, Dr. Jay Shankar, and good afternoon, delegates. And at the outset, I would like to thank the organizing committee of the Tamil Nadu Electrophysiology Council, especially Dr. Jay Shankar, for inviting me to moderate this session that is on ventricular tachycardia. I think without wasting time, I thought we'll go on to the first talk because already we are running late. I'll invite Dr. Kapil to give his talk on PVC-induced cardiomyopathy. Dr. Kapil, please.
Good afternoon, everyone. At the outset, I would like to thank the organizers, especially Dr. Jayashankar, to invite me to this conference. Today, I would be speaking on PVC-induced cardiomyopathy. This is a common problem which we see in our day-to-day practice, and surprisingly, not much data is available as to how to deal with this important problem. Now, in general, arrhythmia-induced cardiomyopathies can be classified as type 1 AIC, which is in where arrhythmia is solely responsible for the LV dysfunction, and the LV function returns to normal after successful treatment of the arrhythmia. And type 2 AIC, which are arrhythmia mediated or superimposed AIC, in which arrhythmia merely exacerbates the underlying cardiomyopathy, and treatment of arrhythmia would result only in a partial resolution of the cardiomyopathy. Now, pathophysiology of arrhythmia-induced cardiomyopathy is very complex and not fully understood, but there are overlapping mechanisms of tachycardia, irregular rhythm, and dyssynchrony, be it left bundle branch block induced dyssynchrony, tachycardia which could be because of SVT, AF, PACs, or irregular rhythm which is mostly seen in AF and PACs and the PVC. Now, in spite of all these factors present, only a few percentage of the patients would develop LV dysfunction, and that could be because of the genetic susceptibility in the different individuals. For example, a sodium channel missense variant and a variant in angiotensin converting enzyme has been shown to be predisposing patients to develop tachycardia induced cardiomyopathy. Now, in animal model, the AIC develops pretty quickly within 4 weeks and passes through stages of compensatory phase, LV dysfunction phase, and then the LV failure phase, in which the calcium channels play an important role. Alongside the neurohormonal activation, vasoactive peptides, and various other mechanisms which may be causative or maybe the effect of LV dysfunction which develops because of the arrhythmia. Now, relationship of arrhythmia to cardiomyopathy can be very difficult to determine. Arrhythmia could exist in a patient for many years before the patient develops cardiomyopathy, and it is difficult to determine whether arrhythmia is the initiator or consequence of cardiomyopathy, very similar to chicken or egg question. Now, it has been shown or it has been observed that LV size can tell you whether it is arrhythmia-induced cardiomyopathy or dilated cardiomyopathy with concomitant tachyarrhythmia. Because in arrhythmia-induced cardiomyopathy, usually the LV does not enlarge that much, and the LV end diastolic diameter and mass index are much smaller compared to the regular dilated cardiomyopathy. Now, PVC cardiomyopathy is pretty unique because it lacks tachycardia and yet the patient develops cardiomyopathy, and now it is recognized as a distinct clinical entity from 2016 AHA scientific statement of dilated cardiomyopathy. Now, PVCs or premature ventricular complexes in general are still ill understood. Now, about 1 to 4% of the patients without heart disease would demonstrate PVC in a 12-lead ECG. But if you do a 24-hour or 48-hour ambulatory Holter monitoring, 40 to 75% of the persons would demonstrate premature ventricular contractions in those recordings. Now, there is a significant variability of PVC with time, and also the PVCs are age dependent, with less than 1% of the children younger than 11 years demonstrating PVC, whereas it can be as high as 70% in people more than 75 years of age. The PVCs are more frequently associated in patients who have had MI, coronary artery disease of any other sort, dilated cardiomyopathy, and heart failure. And almost half of the patients with class 2 or class 3 heart failure would demonstrate frequent PVCs, that is more than 1000 PVCs per day. PVCs are not benign, though most of the people with PVC do not have underlying heart disease or would not develop heart disease in future, but studies have shown that there is increased risk of LV dysfunction and mortality with presence of PVC if you adjust for age and other ECG abnormalities. Similarly, there would be a 6-fold increase in systolic heart failure, which was observed in a large population-based database. Surprisingly, the PVCs also would lead to increased risk of stroke. This was shown in the ERIC trial, and it was attributed to atrioventricular remodeling. The PVC cardiomyopathy in various studies have shown to constitute 3 to 34% of all cardiomyopathy patients, but experts believe that PVC cardiomyopathy is underestimated. In one of the secondary analysis of CHF stat trial, where patients had more than 10 PVCs per hour and LV ejection fraction of less than 40%, this study demonstrated that PVC cardiomyopathy would be seen in 40% of all patients of cardiomyopathy and up to 66% in non-ischemic cardiomyopathy, pretty high number. Now, the causal relationship between the PVCs and arrhythmia-induced cardiomyopathy has been firmly established on the basis of reversal of cardiomyopathy with suppression or elimination of the PVC. Now, how does the PVC or how do the PVC lead to cardiomyopathy? Various theories have been proposed. It could be because of ventricular dyssynchrony, especially when related to the LBBB pattern PVC, similar to RV-induced cardiomyopathy. This has shown to cause changes in the strain pattern of the heart, decrease adrenergic innervation, and also lead to myocardial perfusion defects. Abnormal calcium channel handling or calcium handling from the short coupling interval and abnormal ventricular filling from the post-PVC pause may also be responsible. But it is also interesting to note that the cardiomyopathy also develops in atrial premature depolarizations, and there is no actual relationship between the site of origin of PVC and the PVC mediated cardiomyopathy, which suggests that it may not just be LV dyssynchrony which would be responsible for PVC induced cardiomyopathy. Now, histopathologically, there is no evidence of increased inflammation or apoptosis, and there is minimal fibrosis in patients with PVC induced cardiomyopathy. Similarly, mitochondrial studies do not demonstrate any changes in the oxidative phosphorylation. There are no significant MRI changes in the patients with pure PVC induced cardiomyopathy, and these findings suggest that it may actually be just a functional abnormality rather than any structural change being produced in the PVC induced cardiomyopathy. But the question also remains whether these cellular and molecular changes are in response to cardiomyopathy rather than actual cause of the cardiomyopathy. Now, PVC-induced cardiomyopathy would arise usually from the right or left ventricular outflow tract PVCs, which we all know, but PVCs from non-outflow tract sites can also result in PVC-induced cardiomyopathy. 5 to 7% of the patients who have outflow tract PVC would ultimately develop cardiomyopathy. Now, the most prominent predictor of cardiomyopathy is the frequency or the daily burden of PVC. But there is no consensus definition about high PVC burden, and it can be variably defined as more than 10,000 or more than 25,000 PVCs per day, more than 10% or more than 24% of the total heartbeats per day. According to 2017 AHA-ACC guidelines, more than 30 PVCs per hour or a single PVC on a 12-lead ECG would constitute a high PVC burden. Now, there seems to be a threshold PVC burden which would result in cardiomyopathy, and in various studies it was shown to be more than 16%, 24%, in absolute number 17,000 to 30,000. So there is no actual consensus where you would believe that PVC-induced cardiomyopathy would develop. But it was not seen definitely in when the PVC burden was less than 10% and was predominantly confined to more than 20% PVC burden in one of the earlier studies. But there are studies which question this minimal PVC threshold because LV function improvement was shown when the PVC burden was as low as 6 to 8% and the PVCs were ablated. Now, the length of ambulatory ECG monitoring has important implications. If you increase the Holter duration from 24 hours to 7 days, there would be a doubling of patients who would have more than 10% PVC burden threshold. Now, in one of the more elegantly done studies, though with small numbers, it was shown that a cutoff of 13% PVC burden would be ideal to predict LV recovery with 100% sensitivity and 85% specificity. Now, male sex, increased body mass index, asymptomatic PVC, PVC duration more than 30 months, higher PVC coupling interval dispersion, interpolated PVCs, and retrograde P waves would predict development of LV dysfunction with PVC. Similarly, wider QRS, that is more than 150 millisecond, especially epicardial origin, presence of non-sustained VT, multifocal PVCs, and RV PVCs would also mean more development of LV dysfunction. Now, PVC coupling interval, though it has been shown to be associated with idiopathic VF, most studies do not find a clear relationship between the PVC coupling interval and the development of cardiomyopathy. Thus, there is no risk profile which determines which group of patients would require PVC elimination to prevent cardiomyopathy, and it is advisable that the patients with high PVC burden should have a periodic assessment of their LV function. Now, the PVC-induced cardiomyopathy can present mostly as asymptomatic or with vague symptomatology, but they can also present with heart failure or syncope. Now, the PVC coupling interval ratio of less than 0.5% has been shown to be associated with more symptoms. Now, how to manage these? The first thing should be to rule out any other cause of cardiomyopathy. Now, PVC cardiomyopathy is a diagnosis of exclusion and should be suspected in patients with frequent PVCs more than 10%, especially non-ischemic in nature. Now, it is sometimes challenging to identify whether these PVCs are innocent bystanders or cause of cardiomyopathy. Patients who are older, patients who have other diseases, severe LV dysfunction, significant scar on MRI, less than 5,000 PVCs, multifocal PVCs, non-specific QRS morphology, they are likely to have pre-existing cardiomyopathy with PVCs just being bystanders. How to treat them? You can treat them by medications or by catheter ablations, and in LV dysfunction you have to follow guidelines for the heart failure. Now, beta blockers, diltiazem, verapamil, they are low risk therapies but have limited effectiveness. Beta blockers are still considered for all of the patients. Dofetilide, mexiletine, sotalol, or amiodarone may be more effective, but they are associated with proarrhythmias and other side effects. And now antiarrhythmic drugs are reserved mostly for patients who are not eligible for ablation. In a small study, class 1C agents, propafenone and flecainide, in spite of the previous CAST trial, were shown to be very useful in these patients, even when the PVC suppression was not up to 80%. So currently, catheter ablation is the definitive therapy for PVC-induced cardiomyopathy, and the success ranges from 70 to 90%. It improves ventricular dimensions, MR, and the functional status of the patient. It is also been recommended in CRT patients when the PVC is interfering with CRT functions. And the benefit of the PVC ablation was even observed in patients who have underlying structural heart disease, and LV function improves to 10 to 15% in various studies. In a small retrospective study, catheter ablation was superior to antiarrhythmic therapy with beta blockers, calcium channel blockers, or amiodarone, with 93% reduction in the PVC. Now, which patient would recover LV function? The patients who have more than 25% improvement in 1 week of LV ejection fraction have complete normalization. In another small study, if you could reduce PVCs by more than 80%, that is less than 5,000 PVCs per day, even without complete elimination, the response was very good. And in a small study, a post-extrasystolic potentiation was seen to be predictor of LV function recovery after elimination of PVC. Now, before embarking on ablation, patient comorbidities, patient preferences, and likelihood of successful and safe ablation should all be considered. Spontaneous resolution also has been demonstrated around 12% of the patients in 6 months in the CHF STAT trial. This is all about the PVC cardiomyopathy. Thank you for your patient listening.
Thank you very much, Dr. Kapil, for your excellent talk on various aspects of PVC-induced cardiomyopathy. I think we'll have the discussion at the end of this session. So next, we'll move on to the next talk by Dr. Ram Prakash on fascicular VT. Dr. Ram Prakash, please.
Yeah, we will. This is Dr. Ram Prakash. So we will discuss about fascicular ventricular tachycardias. So coming to characterization and types of fascicular ventricular tachycardia, as we all know, fascicular ventricular tachycardia is a type of idiopathic ventricular tachycardia. It was first characterized by Cohen and subsequently by Zipes, who first described this arrhythmia in 1970s as a relatively narrow right bundle branch block, left axis arrhythmias. So there are a group of arrhythmias occurring in the normal heart with right bundle left axis morphology that arose close to the posterior fascicle and could be induced with atrial pacing. So these were the main characteristics of fascicular VT. Belhassan later described the responsiveness of these arrhythmias to verapamil, to the drug verapamil. So these are also called verapamil sensitive VTs. There are three variants. One is the posterior fascicular VT, another one is the anterior fascicular VT, and the upper septal VT. So posterior fascicular VT will have a right bundle left axis morphology, anterior fascicular VT will have a right bundle right axis morphology, and upper septal VT will have a right bundle normal QRS axis, or sometimes normal QRS with the normal axis morphology. So coming to the concept of fascicular VT, what we see here is a ventricular septal aspect of the left ventricle. It is a highly diagrammatized concept of the fascicular VT circuit that I am presenting here. So what we see here is the antegrade limb. The antegrade limb of the tachycardia is the verapamil sensitive part of the tachycardia that occurs from the pre-Purkinje area to the Purkinje potential area. So that is seen in the upper 1/3 or middle third of the interventricular septum on the septal aspects of the left ventricle, which is just subendocardially. So this is the area where there is the antegrade limb, that is the verapamil sensitive limb of the tachycardia occurs. So it travels antegradely and then it enters the Purkinje potential area, the Purkinje fibers. So the Purkinje fibers are nothing but the arborization of the posterior fascicle, the left bundle branch, the anterior fascicle, the posterior fascicle, then it arborizes into the Purkinje potentials. So it enters into the area where the Purkinje posterior fascicle arborizes into the Purkinje potential, and here from here there is rapid activation antegradally towards the myocardium to the myocardial exit point where it exits out into the ventricular myocardium, and there is a rapid retrograde activation through the posterior fascicle, left posterior fascicle, back into the base of the interventricular septum. And here in the base of the interventricular septum, there is the upper turnaround point. There is the area of slow conduction in the basal septal myocardium, where there is a slow upper turnaround. And then again, it captures the pre-Purkinje area. So that is the antegrade limb of the tachycardia, which is the verapamil sensitive zone. So here we have a fascicular VT circuit. That is the antegrade limb is the verapamil sensitive area inside the subendocardial tissue of the left ventricular myocardial, the septum of the left ventricular myocardium. Then it enters into the region where the posterior fascicle continues as the Purkinje fibers, then rapidly activates in both antegrade and retrograde fashion. And antegradely, it opens up into the myocardial exit point. Retrogradely, it goes back into the basal area of the interventricular septum, where there is a area of slow contraction with the upper turnaround point, and thus that completes the circuit of the fascicular VT. So when there is a breakthrough in the left posterior fascicle area, the morphology of the VT is defined. So that is why you get a right bundle morphology, and there is a left axis deviation because of the site of breakthrough of this tachycardia. Whereas it breaks through in the anterior fascicle, you will have a right bundle morphology and a right axis deviation of the surface QRS complex. So again, what we see here is the ventricular activation, that is the ventricular potential in the ablation catheter, and then just before the ventricular potential, you will see this Purkinje potential, and just before that, you will see a dull pre-Purkinje potential. All these three things are very characteristic of a Purkinje, of a fascicular ventricular tachycardia when your catheter is in the approximate ablation point. So differential diagnosis. So any fascicular VT, the commonest of which is posterior fascicular VT, which will have a right bundle left axis morphology, will be SVT with right bundle branch block, the fascicular VT, or it could be an LVOT VT, papillary muscle VT, mitral annulus VT, bundle branch reentrant VT, interfascicular VT, and a scar mediator scar substrate VT. So out of which SVT with aberrancy and fascicular VT are very close differential diagnosis, for which we will be confused even in the cath lab or even during ablation, for which I will present some points how to differentiate between these two reliably and then to go ahead and ablate the appropriate tachycardia. The LVOT VT, papillary muscle and mitral annulus VT are automatic VT. So initially itself we can differentiate fascicular VT from these three automatic VTs, whereas a bundle branch reentry, interfascicular VT and scar substrate VT, you will have a definite ventricular dysfunction. So that is not the purview of our discussion. So like I told you, when there is an underlying LV dysfunction or scar, which is associated with the other three VTs with right bundle left axis morphology, we will not be discussing. So two groups in the normal heart is SVT with RBBB aberrancy and fascicular VT, which are reentrant tachycardias, and automatic VTs like papillary muscle VT, LVOT VT, and mitral annulus VT. So these are the VTs that occur in structurally normal hearts. So coming to induction with atrial pacing. So the one very important concept or aspect of fascicular VT, it is inducible by atrial pacing also. So is SVT with right bundle branch block morphology. So SVT with right bundle branch block morphology and fascicular VT are both inducible with atrial pacing, whereas automatic VTs are unlikely to be induced by, or it is not possible, very, very unlikely to be induced by atrial pacing. So this is an example of our case where we could induce the VT in the right part of the tracing. The VT could be induced by atrial pacing from the CS. So CS78 induction resulted in induction of a right bundle left axis morphology VT. So this is very likely to be a fascicular VT. So this is the intracardiac tracings, again showing the induction of a VT by atrial pacing from CS78. So there is an extra stimulus and induction of VT with VA Venki back. So here what we see is ventricular right bundle left axis morphology VT with atrial progressive prolongation of VA conduction. Then there is a dropped VA conduction, very likely to be a VA Venki back phenomenon, and this could be this is very likely to be a fascicular VT. So induction by sustained sustained VT by ventricular pacing, again by programmed stimulation, if it is inducible, then it is very likely to be a fascicular VT rather than a right SVT with right bundle branch aberrancy, and automatic tachycardias also become less likely if it is inducible by ventricular programmed stimulation. Whereas if it is inducible by isoproteinol infusion, then it is more likely to be automatic VTs. So coming to the third thing, that is the entrainment from atrium. So during tachycardia, if you try to entrain the VT or the broad complex tachycardia from the atrium, this gives you a very, very interesting insight into the mechanism of the tachycardia. So SVT with aberrancy and fascicular VT both could be entrained from the atrium, because fascicular VT is very closely associated with the conduction system of the heart, that is in the posterior fascicle. You will be able to entrain it from the atrium, whereas entraining automatic VTs is very unlikely. All you will end up doing is you may end up in overdrive suppression, or there will be total dissociation of atrial pacing and the ventricular complexes. So this is the entrainment. So what we see here during ventricular tachycardia, the initial panel is the ventricular tachycardia. You are trying to entrain it by CS5-6 pacing, that is from the atrium, and there is a clear entrainment that is occurring during the tachycardia, and after that there is the tachycardia continues. So you are pacing, the tachycardia cycle length is around 370 milliseconds. You are pacing at 330 milliseconds from the atrium, and there is a clear entrainment of the tachycardia from the atrium. One interesting phenomenon that we can note is when there is entrainment from the atrium, makes QRS narrow in fascicular VT. So when there is a capture, the QRS will become narrow, whereas aberrancy will persist in SVT with aberrancy. So this is what is seen in this slide. The QRS becomes narrow during the time of entrainment in fascicular VT, which is seen very clearly here, whereas the wide QRS is there during tachycardia. So this makes fascicular VT very likely. So coming to entrainment from ventricle, so fascicular VT can produce progressive fusion, and manifest entrainment and progressive fusion is possible in fascicular VT, whereas automatic tachycardias will only exhibit overdrive suppression. So coming to the differentiation of SVT with aberrancy versus fascicular VT, what we can see is the HV interval. The HV interval during SVT and normal sinus rhythm is the same, because the axis of activation is the same from the His bundle to the posterior fascicle to the Purkinje fibers. So the same forward axis. So the HV interval is your A plus B. B is from His bundle to the Purkinje potential, and from the Purkinje potential to ventricular myocardium is A. So these two intervals will amount to the HV interval during sinus rhythm or an supraventricular tachycardia. Whereas in fascicular VT, the circuit occurs here, like I showed you in the concept of fascicular VT, there is simultaneous retrograde activation from the Purkinje fascicle junction back into the His, that is your B, and your A is forward activation. So your HV interval will be A minus B. There you will typically get a negative HV interval in fascicular VT, whereas you will get a same HV interval as that of normal sinus rhythm in SVT with aberrancy. So this is what we will demonstrate in this case with a 22-year-old patient with a recurrent tachycardia. So Tachy 1, we were able to induce 2 tachycardias of RBBB morphology. Very interesting. So Tachy 1 is also of an RBBB morphology, and Tachy 2 also is of a RBBB morphology. So positive deflection in V1. So what we see here in the previous one, there is a typically little bit wider QRS complex, whereas in the second panel there is a RBBB morphology, but the QRS complex nevertheless is a little bit narrower than Tachy 1. So coming to the tracings of Tachy 1 intracardiac ECGs, initially there is a 1:1 clear 1:1 VA conduction during the tachycardia. So it is very difficult to differentiate it between the SVT with aberrancy versus a ventricular tachycardia or fascicular ventricular tachycardia of RBBB morphology. So to help in this, what we could see here is the HV during sinus rhythm. before induction of tachycardia, the HV during sinus rhythm is 38 milliseconds. And when we go to the tachycardia, that is tachy 1, what we see here is HV during tachycardia is minus 19 milliseconds. So to show you, the ablation proximal is kept in the left side, is recording a left sided His here. So this is the His potential, this is the ventricular potential, this is the atrial potential. So this is the beginning of the His potential, whereas this is the beginning of QRS, whereas the His potential is buried inside the QRS, giving rise to a negative HV interval. So this clearly shows this tachycardia is that of a fascicular ventricular tachycardia. So the comparison of HV interval, so this is during tachycardia, this is HV interval is a negative, and just after termination in the same the catheter position, you see AHV, their HV is around 39 milliseconds. So the HV interval is clearly different. It is a negative HV during tachycardia, which clearly demonstrates this tachycardia of fascicular ventricular tachycardia. So when then again during continuation of tachycardia, we were able to demonstrate VA block during the tachycardia, which again clearly rules out a SVT with aberrancy. So coming to tachycardia 2 in the same patient, what we saw of after like the two types of tachycardia were induced. The second tachycardia has the same HV interval as that of the sinus rhythm. So this is the H, this is the V, and this is A, and the HV interval is same as that of sinus rhythm. So this is a SVT with aberrancy. In this case, it is a AV nodal reentrant tachycardia with aberrancy, right bundle branch block. So this patient had both fascicular VT and AVNRT with RBBB. So which was clearly demonstrated by this concept of HV interval during tachycardia and HV interval during sinus rhythm. So comparison. So planning the ablation strategy. So SVT, you can ablate the slow pathway, the activation path, accessory pathway, or activation mapping in this thing. And fascicular VT, we have to ablate the best possible way to ablate a fascicular VT is to match the Purkinje potential that is at the junction of the posterior fascicle and the antegrade limb to the breakthrough point of the myocardium. So this is the area of ablation in fascicular VT. So what we could see is in the fascicular or Purkinje potential during sinus rhythm and during tachycardia should be the same, should almost be the same during the sinus rhythm and during tachycardia. So when in sinus rhythm it is far away, then it means that you are mapping the Purkinje potential in the nearby neighboring areas, the bystander areas, or possibly arborization of the anterior fascicle, whereas in the posterior fascicle or in the nearby area where it is in the circuit of the posterior fascicular VT, the Purkinje potential to the ventricular activation distance will almost be the same. So this is where you should target your ablation for termination of ventricular posterior fascicular VT. Thank you.
Thank you very much, Dr. Prakash, for bringing out various aspects of the fascicular VT very nicely, and we'll have the discussion at the end of the session. Moving on to the next topic, Dr. Narasimhan will be talking to you on inflammatory VT, the management. Dr. Narasimhan, please.
Good evening, Dr. Chandrasekhar. Am I audible?
You are audible.
Yes, sir.
Yeah, you are audible.
Good evening, Dr. Chandrasekhar.
Thank you.
At the outset, I would like to thank the chairpersons as well as the TNEPIC for this kind invitation. It's very important in the modern days, we just get swamped by technology. Some of the basic findings by these pioneers centuries ago had paved the way for our understanding of granulomatous disorders. Jonathan Hutchison describing the sarcoid and Robert Koch a tuberculous granuloma. So I've been assigned to speak about inflammation and VT. So I'm going to first see the most important thing when you have so-called an idiopathic VT or a dilated cardiomyopathy is to ascertain, is there a myocardial inflammation? Most of the things get missed out because we don't suspect or we don't confirm there. If there is an inflammation, what is the underlying cause? Why do certain inflammatory conditions cause VT, whereas certain inflammation, for example, lymphocytic myocarditis, you routinely see. You see COVID myocarditis so often, but you don't see the same spectrum of VT as you see in sarcoid or in myocardial tuberculosis. And how do you manage these patients? First of all, let me just start as a clinician. Why do we care? Why is it relevant? This disorder is more common than we think. There is no consensus on management. The whole field is evolving. And the results of catheter ablation are uniformly poor, especially when you don't realize there is an ongoing inflammation. I'll present them some data from Stevenson's lab, so on and so forth. ICD shocks can be frequent and could lead to battery depletion in these patients. And inappropriate steroids, when you empirically start steroids, you know the problem of steroid side effects. And most importantly, there is a lost opportunity because these patients, if you don't recognize inflammation, for example, in myocardial infarction, 6 to 12 hours is a golden hour. Whereas this is a chronic smoldering inflammation lasting for months. And if you don't recognize and go be treating with antiarrhythmics or ablation, you have lost the opportunity to prevent potentially a dilated cardiomyopathy and a transplant. So what are the simple clinical clues that we have found in our practices? If you take a person in, especially a developing country like ours, if there is a past history of having been treated for tuberculosis, either lymph nodal or pulmonary tuberculosis, there is an 8-fold higher risk of sarcoid in those patients. Some 2-3 years prior to presentation, patient had some Bell's palsy, some skin nodules in the leg. When a person for the first time presents with wheezing as an adult at the age of 40 years, you need to become worried. You don't generally have this as an asthma. What are the clinical clues in the ECG, echocardiographic clues? One of the early clues we find on echo is the septum fails to thicken in systole. In parasternal long axis, especially when you look at the anterior septum, you would find between systole and diastole, the distal septum thickens adequately, but basal septum does not. And this obsession about the ACE level should go away. In our experience, we have published this. Among 90 patients with proven cardiac sarcoid, ACE was elevated in less than 10% of the patients, serum ACE. Serum ACE is very useful as a part of systemic sarcoid, but when it's isolated cardiac sarcoid, it doesn't really is not that valuable. And advanced imaging techniques fail to this. Again, this we have put together in the past, simple presence of fascicular VT, presence of fascicular block, bundle branch blocks, or fractionation in a person's resting ECG, and he presents with so-called idiopathic PVC, you should think that this is not idiopathic. VT occurring in the setting of wavy block, monomorphic VTs, pleomorphic VT. This is something which we reported about almost 8-9 years ago. When you have variation in cycle length and morphology, even subtle variation that is not typical of an idiopathic VT, you should suspect an ongoing sarcoid granuloma. Presence of VT in the presence of dilated cardiomyopathy and the patient does not have a family history, you need to think about inflammatory causes. Idiopathic LV aneurysm, these can be the presenting manifestation. I think we are all aware there are a host of conditions which can cause myocardial inflammation. Commonest one of the cardiotropic viruses and hypereosinophilic syndrome, so on and so forth. But you don't find ventricular arrhythmia in a lot of them. Why is that so? This is a very elegant study which came from Boston, which looks at patients. This is staining for connexon 43, plakophilin, desmoplakin. Compared to patients' lymphocytic myocarditis, these connexons, everything is maintained very well. Whereas in sarcoid, there is a disruption of the cell-to-cell junction resembling very closely ARVC. ARVC and sarcoid, you can find that there is slowed conduction because of disruption of cell junctions that seems to be unique to some of the granulomatous disorders causing VT, whereas you don't find this in a run-of-the-mill lymphocytic myocarditis. Several systemic inflammatory diseases. Suppose a patient is being treated for rheumatoid arthritis, joint is burnt out rheumatoid, and then the patient comes to you with VT 4 or 5 years later. You need to see whether there's cardiac reactivation or whether there's a healed granuloma in the heart. So mainly, I would concentrate on cardiac sarcoid, cardiac TB, and tuberculous sarcoidosis. Let's start with a case. This is a patient who underwent a catheter ablation for so-called idiopathic VT. Then they recognized a couple of months later that it was a sarcoid, undergoes catheter ablation and then followed by single chamber ICD, recurrent ICD shocks, and then sarcoid diagnosis is made, treated adequately with steroids and methotrexate. The FDG uptake resolves, VT resolves. However, 2 years later, he presents with recurrent shocks. How do we approach this? Repeat PET shows relapse of cardiac sarcoid. So you should understand this is like multiple sclerosis, a disease of relapses and remissions, and you should be cognizant of this. The first manifestation of relapse may be atrial arrhythmia. One of the clue is this, what I mentioned. When you see a varying cycle length and the pleomorphism of morphology, that generally suggests an active inflammation rather than a healed granuloma. So this is what this patient is from Sri Lanka. And once we, in fact, he came prepared for an ablation. Once we saw these things, we realized, hold on, this is not going to be amenable for ablation, and we intensified the immunosuppression for this patient. This was reported by one of my colleagues, wrote this up a couple of years ago, saying that irregular cycle length and pleomorphism of VT is suggestive of cardiac inflammation. Please remember, this is polymorphic VT, where it's continuously evolving, whereas pleomorphism is this distinct morphology varying from beat to beat. This is another of our patients who presented with incessant VF and an aborted sudden death, turned out to be a granulomatous myocarditis presenting as Brugada syndrome. And people have reported inflammatory changes presenting as early repolarization syndrome. So the spectrum of ventricular tachycardia in patients with underlying disorder inflammation includes idiopathic monomorphic VT. It can be pleomorphic in morphology or multiform PVCs and PVCs of multiple VT with high-grade AV block. It can present as channelopathy. For example, people have demonstrated that there is an active inflammatory infiltrate in the ganglia of patients who present as channelopathies. And it can masquerade as ARVC and ventricular tachycardia and valvular disease sometimes. So how do you proceed to investigate? Number one, basic chest X-ray, GAD MRI, but our preference has been an FDG PET. If you want to pick up an early sarcoid, suppose the patient has a normal LV function, first time presenting with VT, the yield of FDG PET is much better in our center rather than MRI. Always in a developing country, rule out tuberculin skin test needs to be done. Serum AS levels, yes, it is very low diagnostic yield, but if it's elevated, it's a very useful prognostic marker, because next time when he comes, you don't have to repeat a PET. You can just go ahead and monitor the AS. We are obsessive about getting a tissue sample to get a gene expert from the sample, or if you don't have the facility, you can at least do a PCR culture and stain and culture of the lymph node sample. Broadly, you have three spectrum of disease. One is when the culture from the lymph node is positive, it's myocardial tuberculosis. Please be aware, this patient, when you start on anti-tuberculous therapy, there may be a paradoxical worsening of VT because of expansion of granuloma. It's prudent to cover them up with a low-dose steroids when you start. And the other end of the spectrum is sarcoid, when we don't know the antigen which has triggered the granuloma. And the other end of the spectrum is sarcoid. And of course, the mycobacterial antigen, which was left behind in the tissue, can incite a sarcoid-like response, and that is called tuberculosarcoid. So accordingly, your treatment has to be a classic 4-drug ATT or a combination of ATT and steroids. And of course, steroids with variable immunosuppression would be the way to go. This is a patient with tuberculous myocarditis showing a significant improvement 3 months after treatment, resolution of inflammation on PET. Now, one of my colleagues, Dr. Thatchell, put together this data several years ago, and it was never written up for whatever reason. When you start patients with tuberculous VT, these are all patients with mycobacterial culture being positive from the lymph node. And after starting rifampicin and the 4-drug regimen, a few of them develop a VT storm thereafter before they settle down. So the mistaken impression that it's tuberculous granuloma, you don't need an ICD, may not always be true, and some of these patients can give you trouble. I'm not going into the depth of this. We should understand that sarcoid is not a single disease, and it has a variable disease phenotype as well as the severity, depending on the underlying HLA-DR in a given patient. So our standard dosage is 0.5 milligram per kg of steroid. Right up front, we start them on methotrexate. Sarcoid VTs, it's prudent to first give an ICD and then start steroids for fear of wound infection, ICD wound-related problems. Just delay the steroid by a couple of days, implant the ICD, and then proceed. If they fail to respond, you need to intensify the immunosuppression, including the biologicals like infliximab and adalimumab in a given patient. I would just illustrate this with a case example. This is a patient, the same patient having multiple morphologies of VT. And he was, again, the story is he presented in November of 2016, diagnosed as idiopathic RVOT, attempted ablation, several antiarrhythmic drugs, PET biopsy, confirmed sarcoid granuloma. And with a lot of medications, he was the VT quietened. And then a couple of months later, he presents with incessant VT. He was throughout in VT when a combination of several antiarrhythmic drugs were used, and then multiple overdrive attempts at overdrive pacing, endo-epi ablation, stellate ganglion block on both sides. EF steadily deteriorates, and he was listed for a transplant. Now, it is at this stage we gave a dose of adalimumab, and there's a dramatic response. Doses were consolidated. He still comes for a follow-up with an EF of about 30, 38 or 40%, class 1. Now, this is again, Abhijit, one of our colleagues, looks at it. While most patients respond to conventional dose of steroids and methotrexate, a small proportion of patients have a worsening of their PET uptake despite giving steroids and methotrexate. And this we labeled as steroid resistance. This is well known in CNS sarcoid, but for cardiac sarcoid, we just hand it over. Please be aware of this. When the patient doesn't resolve, repeat a PET at the end of 3 months. If that the PET doesn't resolve, you may have to intensify the immunosuppression. Now, switching gears, this is a report from Bill Stevenson's lab about VT ablation. A whopping 86% of them had recurrence of VT, and a lot of them were young patients going on to be listed for transplant, dying while waiting, and so on and so forth. The importance is, when you go through the paper, you realize we are so fixated on the mechanical abolition of VT, but very often you need to wonder whether there's an ongoing inflammation, which was not done in this case. One inflammation has completely subsided. Very often the VT comes from the substrate. You can, in the interventricular septum, this is a patient mapped in the septum of the RV, the LV. You find that the LV had a manifest entrainment here. So, and a concealed entrainment was from the RV surface. Very often you'll have channels which are responsible for VT, which can be successfully ablated. Japanese authors have reported a Purkinje relationship to Purkinje related VT in sarcoid. So you need to tag the Purkinje potentials of interest when you're mapping. And very often, this is a patient with tuberculosis, apical uptake, same area. When the tuberculous granuloma heals, the same area we had to do an epicardial ablation and an endo ablation simultaneously to get rid of the VT. This is another patient with, no, for some reason, it's not playing. Okay. We had to do a bipolar ablation on this patient between endo and epi to get rid of the VT. These are all patients where you have abolished the VT, and one of the frustrating problems is they tend to develop a lot of pericardial adhesions, and some of the areas you may not be able to reach. We try to open up the adhesions with a bent catheter. If it doesn't yield, you localize the area with reference to a coronary artery and then tell the surgeon this is close to, say, for example, OM1, OM2. He will design the incision accordingly. You can see a catheter that is taped to the surgeon's finger, and we use this to map and ablate. This is the electrogram obtained from the surgeon's finger, and you can irrigate with an ice saline at that time to get rid of this VT. So this is already published. I would strongly recommend people to go through. I think this is a very practical way of dealing with VT in inflammatory disorders. First and foremost is to assess whether there is an ongoing inflammation. If that be the case, do not take them to the lab. Better treat them adequately, get rid of the VT, and then take up. We have moved away. The original manuscript when we wrote was we were using 1 milligram per kg, but we saw a lot of avascular necrosis and steroid related complications. We have started scaling down steroids and adding methotrexate right up front to minimize these complications. So, Chairman, ladies and gentlemen, granulomatous myocarditis is associated with multiple morphologies. It's not uncommon to induce non-clinical VTs in the lab, and this could be related to patchy involvement of the myocardium and ongoing inflammation. Lesions in granulomatous myocarditis, the circuit can be transmural, intramural, endo, or epi. Hence, almost 50% of our patients would require both endo and epi approaches to get rid of the VT if you're targeting for ablation. Please consider ablation only after you have adequately treated the ongoing inflammation. So broadly, when a person presents with idiopathic VT, confirm if there is an inflammation and then ascertain the cause of inflammation. Therapy should be tailored according to the disease activity, and this improves the clinical outcome. ICDs are as of now recommended for all VTs in CS because we don't know how to risk stratify, and RFA is a useful adjunct to antiarrhythmic therapy and ICD. And I would like to thank Tamil Nadu EP Council for the kind invitation, and thank my colleagues Dr. Muttaya and Daljit who made these presentations. Thank you very much.
Thank you, Dr. Narasimhan, for your lucid presentation on various aspects of inflammatory VT, and you brought out the role of steroid and immunosuppressions straight away. We should not go for ablation when there is an active inflammation. Very important practical points you brought out. And we'll have the discussion at the end of the next talk. And next up, I'll invite Dr. Ullas Panrangi to give his talk on scar VT ablation. What are the targets for ablation? Dr. Ullas, please.
Hello, everyone. Now let us discuss about the ventricular tachycardia ablation in structural heart disease, where the scar is supposedly to play a crucial role, and how to identify the scar for ablation. Few words about the scar-mediated ventricular tachycardia. We all know this kind of a tachycardia is recognized as a cause for mortality and morbidity. Scar-mediated ventricular tachycardia is most commonly associated with myocardial infarction. It is also associated with the varying etiologies of cardiomyopathy. It could be ischemic, non-ischemic, even idiopathic dilated cardiomyopathies, or varieties of infiltrative and inflammatory disorders of the heart. ICDs, we all know, are the cornerstone of therapy when you are dealing with scar-mediated VT. We know that it improves survival. The disadvantage of ICDs is it does not prevent the recurrence of ventricular tachycardia episodes. And each time the VT is treated by ICD, typically by shock, it increases the morbidity. And sometimes it hastens the death because of the heart failure. So ICD usage should be as minimal. Seems to me that if you target the scar which is responsible for ventricular tachycardia for ablation, with or without addition of antiarrhythmic drugs, might improve the quality of the life of your patient, increases survival if he is affected with scar-mediated VT. The VT ablation has been shown to reduce the ICD usage by 60 to 80%. So we should all be trying to learn how to deal with the scar-mediated VT. The commonest electrophysiological mechanism that is attributed for the sustenance of the scar VT is re-entry. The re-entry requires essentially a zone of slow conduction, which is represented on the screen by the electrograms as a continuous local electrical activity. That is very critical, which acts like the stimulus for the re-entry. For the first time, the mechanism of the scar VT as the re-entry was documented by Mark Josephson and his team in 1978. And that particular demonstration, according to me, is still the golden reference for all our mapping of scar VT. They very lucidly demonstrated for the sustenance of a ventricular tachycardia in presence of a scar, it requires delayed conduction in a particular area. And the VT initiation requires further slowing of the conduction in that area, which is represented by fractionation of the electrograms, occupying the long duration at the local site. That is the initiation. And the maintenance of the ventricular tachycardia, they demonstrated that it requires the continuous electrical activity throughout the cardiac cycle, and which they called local fibrillation. They also documented that either a spontaneous or by ablation, if you terminate the continuous activity locally, it also leads to termination of the ventricular tachycardia. So for the first time in 1978, what that has been documented, how to show a particular area as a zone of slow conduction or the isthmus of a re-entry. What that had been shown in 1978, most of the concepts are being adopted even now and practiced. For example, I'm trying to show here pictorially what actually they demonstrated in that lucid paper. Let us imagine this is the entire white area. It's a normal myocardium, and because of certain pathology, there is an area of a scar, and in the midst of the scar, there is still a tissue in the border zone of this scar, a tissue which is not as necrotic, as fibrotic as this dark area. It is not as healthy as this white area, which is represented here in the gray zone. So this area still is viable, and hence it is electrically active, but conducts slowly. So this, if this is available in the heart, it could be the isthmus for a re-entry. A slow zone conduction, and by the time it comes back, so again it's recovered and it goes on. So this is what exactly they demonstrated way back in 1978. What is the standard practice of the VT scar mapping and ablation? The goal is to target the isthmus of the reentrant VT circuit. There are two fundamental mapping techniques. One is the conventional, which you can call two-dimensional, and the other one is by three-dimensional. One of the fundamental mapping techniques is to localize the substrate. For example, which I mentioned is low voltage or a continuous activity. and which probably is the potential isthmus. The second step, or the second fundamental step, is to confirm that the substrate what you identify is indeed is the isthmus of the tachycardia circuit. How do you map the substrate? By conventional mapping, as I was quoting, if in a particular area, if you start showing some local abnormal ventricular electrograms, either during the sinus rhythm or a pacing which represents a slow zone of conduction, and if you also show those are all low amplitude, that demonstrates there's a scar and there's a viable tissue. By 3D techniques, you can identify a zone which could be potentially a scar or an isthmus. And a scar is defined as the local voltage when it is less than 1.5 millivolts. And then you could also show by activation map, either during the sinus rhythm or pacing, that particular area is conducting slowly. Let's have an example of a substrate map and proof of the substrate as a part of the circuit. For example, imagine the area of the interest if your rowing catheter arrives and local electrograms show either during the sinus rhythm or in this particular case, you are pacing. And if you are identifying the areas of low potentials, you're also identifying the potentials are split, they're longer duration. If this is the area, this is potentially a scar zone, border zone, area of slow conduction, which could be potentially an isthmus. So this is what is the conventional quadrupolar or a multipolar electrode you have placed in. If you place this information into the 3D electroanatomic mapping system, it will automatically is covering in the background what is the voltage. For example, this is the voltage map. There's a large area of the scar which is represented gray, and here is the violet color. Here, this is the healthy area, and this is the border zone. And if your catheter is getting rowed, and if it arrives here, you could notice these kind of potentials, and an activation map is showing a crowding of the colors here, which represents the slow zone of conduction, which we would call as a deceleration zone. Further confirmation that this particular area is indeed the isthmus requires another step of inducing the ventricular tachycardia if it is stable. No one has to make use of that situation where the patient is having that clinical ventricular tachycardia, demonstrates the continuous activity in that zone. And if you also feed this information into the 3D system, if you make an activation map of the ventricular tachycardia all along the endocardium, the various regions, you could identify a particular area, which is again a crowding of the color, which represents the zone of the slow conduction, and which is exactly the place where during the sinus rhythm, the ventricular pacing, you had low voltage and slow conduction. And this is the site for this is the target for ablation. Let me show a case of 70 years old male, old anti-wall MI, ischemic cardiomyopathy, incessant VT, had a ICP with multiple shocks, and he had to be taken for RF as the last measure. The protocol would include a VT, and if it is hemodynamically stable or not stable, we'll have to check. Most likely, if you take him to the lab, it's going to be unstable, so you should be prepared that the patient needs to be intubated. Now, it's a last resort. You cannot just take the patient back to the ward without doing a complete job. Sometimes we require to be doing an epicardial ablation in such situations, so we should be considering proactively an epicardial access pre-heparin. And because it's going to be hemodynamically unstable, you should be planning to do the mapping during the sinus rhythm or ventricular pacing. And then after you need to be confirming that substrate participation by pace map first, and then at least once during when the VT is induced. So inside the EPA lab, as expected, it was easily inducible, the tachycardia, but it was hemodynamically unstable, as expected. So the substrate map during the sinus rhythm, the ventricular pacing were performed. For example, as I said, this gentleman has had extensive anterior MI. And if you start doing the voltage mapping and if you define the scar as less than 1 millivolts, you can see there's a large area all along the anterior wall. It's all gray, it's all scar. And there's a tiny island in the midst of this large area of the scar, which is showing some viable tissue. Reconfirm that, go again and check. Indeed, it was more than 1 millivolts. And now to figure it out, are we missing out some more viable tissue? You can further adjust the color coding in the form that the scar here, it is defined as less than 0.3 millivolts. You get more tissues, which is appearing to be viable tissue. And if you further reset the definition, go below 0.2 millivolts, you get larger area of viable tissue. So this probably is potentially an isthmus area that we'll have to reconfirm it further. Either during the sinus rhythm or in this case, it was ventricular paced rhythm going on. And in this area, there's clearly a slow zone of conduction, split potential, slow voltage, so scar and slow conduction. And if you do an activation map during the ventricular pacing, again, you will find in the same area in the anterior wall, in this particular area, there's a crowding of the curve, which is suggestive of slowing of the conduction. And if you also, the mapping during sinus rhythm or ventricular pacing is sometimes associated with fallacy. It is good to do the mapping at least once during the ventricular tachycardia. However much we know that it's going to be unstable, try. So in this particular case, which was hemodynamically unstable, was made stable. Anyway, the patient was in the general anesthesia. Sometimes during general anesthesia, what is clinically unstable VT might be actually stable. And here in this case, we used high doses of dopamine up to 15 micrograms per minute to achieve a hemodynamically stable VT. And of course, that was a clinical morphology. So we had done this mapping in the ventricular pacing, voltage mapping, what we thought along the scar, there was a viable tissue. We thought it was isthmus, which was reconfirmed here. In this particular area, for example, when you put multiple catheters here, there's a continuous electrical activity. What was considered the isthmus at the entry and the exit, they all were concordance with our assumption. And then if you do the quickly activation map during that tachycardia, you could still demonstrate in the same area there is a slowing of the propagation. So that was what is the isthmus. So there's one final step we could still do, that in that particular area during the ventricular tachycardia, if you have an opportunity to kind of in training, and then if that is concealed entrainment with a similar morphology, post-pacing interval is exactly like that of a tachycardia cycle length. Well, I think you are almost assured that you bring in a catheter in that area, then you can terminate the tachycardia. So we delivered some linear lesions all along the isthmus, and the tachycardia was terminated. So to conclude, what I would like to say here is that we have come a long way, right from 1950s, when there was an anatomical correlation of a ventricular tachycardia with the clinical anatomical correlation of aneurysm with the clinical ventricular tachycardia. And in 1960s, actually surgical excision of these aneurysms leading to the relief of the ventricular tachycardia. In 1980s, percutaneous techniques employing radiofrequency ablation brought some relief from the VT. And in the last 2 decades now, we have really achieved a great success of ventricular tachycardia ablation because of the employing the 3D techniques, including even the epicardial access. And there are various ways of delivering the lesions. So finally, I would like to say that scar VT ablation is feasible, it is safe, and it is achieving the goal of minimizing the ICD usage. Thank you. I should be saying here that this presentation, including all the VT ablation work, is a teamwork. And I'm fortunate I got some brilliant group of people working in the department. So these are the fellows and the cardiac technologists who have helped me. Thank you.
Thank you, Dr. Ullas, for your excellent talk on the scar VT ablation. You brought about various interesting aspects of what are the targets for ablation and various types of mapping and how to do the substrate mapping in sinus rhythm and during tachycardia. I think we'll have the discussion at the end of this session, and because of want of time, we'll move on to the next talk by Dr. Raja Selvaraj on cuspal VT recognition and management. Dr. Raja Selvaraj, please.
Hello, everyone. Outflow tract VTs, which arise above the level of the valves, occur both in the right side, in the right ventricular outflow tract and the left ventricular outflow tract, and they form a somewhat challenging subset of outflow tract arrhythmias. So, in this talk, I'm going to briefly discuss how we recognize these so-called cuspal ventricular arrhythmias and how we manage those. So first, of course, with the outflow tracts, the anatomy is complex and you need to have some understanding of this. This is an excellent figure from Dr. Asirvadam's group. And so the cross-section, which you're fairly familiar with, this aortic valve is central. The pulmonary valve actually sort of lies anterior to this and at a higher plane compared to the aortic valve. And you have the facing sinuses on the aorta, which face the pulmonary, which form the left and right cusps, from where the coronaries arise, and the posterior non-facing is the non-coronary cusp. Similarly, in the pulmonary valve, the sides facing the aorta are the left and right cusps, whereas you have an anterior cusp, which is non-facing. So, in terms of terminology, though we are calling this a cuspal VT and cuspal arrhythmias, the cusps are really formed by the valve cusps, and they don't have any muscle. Arrhythmias don't arise from that. So it has been said that the better terminology is to call these as ventricular arrhythmias arising from the aortic sinus of Valsalva. And the sinus actually can have muscular extensions from the ventricular outflow tract extending into them. And note that you have the right non-coronary cusp and the left coronary cusp here, and you have the mitral valve continuity across extending mostly across the non-coronary cusp and part of the left coronary cusp here. And this area, you don't often see muscle fibers, so rare to get arrhythmias here. So mostly arrhythmias really come from the right coronary cusp, which is in very close relationship to the posterior RVOT, and also from the left coronary cusp. And also note that you can have a triangular area here where the outflow tract muscle extends between the leaflets. So this is called the interleaflet triangle, and especially the interleaflet triangle between the right and left coronary cusps might also be fairly high, like fluoroscopically it look like it's above the level of the aortic valve, but this might be better approached from below than from above. So now when it comes to the outflow tract anatomy on the right side, like I said, the difference from the left side. So on the left side, when we see in an RAO view, when you see something anterior, we know it's right or left, and posterior is non-coronary. Here is the reverse. Something that is anterior is the anterior coronary, anterior cusp, and posterior you have to differentiate whether it's right or left, and then that differentiation you do in the LAO view, where the right is more rightward and left is more leftward. And so, for example, in this case, which is from a series published by Dr. Narasimhan's group, in the RAO view, you see this is posterior, so we know this is not the anterior pulmonary cusp, this is left or right. And then in an LAO view, you see it's leftward, so now we know this is the left pulmonary cusp. ECG identification, broadly for outflow tract arrhythmias, a broad rule is that you use the limb leads to identify that an arrhythmia is coming from the outflow tracts. That is, typically you have complete negative complexes in AVL and AVR, and you have tall R waves in 2-3 AVF. So once you see this in the limb leads, you identify this is an arrhythmia coming from the outflow tract. But differentiating left versus right is mostly comes down the precordial leads. And the first thing you look for is the transition. And if your transition is beyond V3, it's usually a right-sided origin, whereas if transition is before V3, it's a left-sided origin. The transition at V3, things can be a little bit more complicated, and that's where probably the best to use is to look at the R wave in V1 or V2. And if this R wave is broad or it's tall, think of a left-sided. So this is broadly the rule, and specific cutoffs have been given as various other algorithms have been given. Basically, the width, if it is more than 50% of the overall QRS duration, or the height is more than 30% of the total height, think of left-sided arrhythmias. And there is also, one can understand that there can be rotation of the heart so that the transition may look shifted early. But so this, you can correct for this by looking at the sinus transition. So there was an index described, but a simple way is to just look at whether the transition of the arrhythmia or the PVC is earlier than the sinus or later than the sinus. And if it is earlier than the sinus, then you think of a left-sided origin. Algorithms have been described to differentiate something arising from the PA from those arising in the RVOT. It sort of makes sense that it will have a higher R wave, and AVL to AVR Q ratio is higher with PAVAs, but this may not be true for all locations in the cusp. Subsequent studies have shown that these are not really very specific indicators. Sort of interesting paper came from Dr. Shiv Kumar's group showing this. And this might be helpful occasionally clinically. Sometimes you see these outflow tract PVCs which have a significant variability in their coupling interval. So normally PVCs are fairly close coupled, and here you can see that not close coupled, the coupling interval is fairly constant, whereas here you can see the coupling interval keeps varying. And when you see this amount of variability, you should suspect that it's arising from above the level of the valve. When it comes to EP and identification of these arrhythmias, one helpful thing to do whenever you suspect a possible left-sided or septal focus is to put a CS catheter deep. If you place a CS catheter deep and you're mapping in the great cardiac vein, looking at the timing of this, you can quickly know whether you might have to go and map on the left side or not. If this timing is very good, it's probably going to be close to the summit. You might have to map at the GCV primarily. If it is close, like 0 or -10, you might have to map in the aortic cusps. Whereas if it is very late, you might directly start with the RVOT mapping. And an important signal to recognize when mapping these cuspal arrhythmias, both on the right and the left side, is to identify a separate potential related to the muscle fiber which is extending, which is separate from a larger far field ventricular potential that you see. This has been described on both sides, like I said here, and I'll show you some examples. This is from one of our left coronary cusp PVCs. You can see a PVC here, you see a sinus beat here. During the sinus beat, in the ablation catheter which is sitting in the left coronary cusp, you can see two signals. There's and this larger signal represents the left ventricular muscle, whereas there's usually a higher frequency signal representing the muscle extension in the cusp itself. And this comes later than the order of these signals gets reversed during the PVC, and then the first signal comes very early. So this is a very good marker when you see these two, that this is a good sign to relate. You can see how localized this is. It's not seen at all in the proximal this. And this is from Dr. Narasimhan's group in the pulmonary cusp. Again, you can see two signals, a larger signal during sinus rhythm and a smaller later signal. And this small late potential becomes a pre-systolic potential during the PVC and is followed by the larger signal. Again, the signal reversal suggesting this is a good place to ablate. When it comes to unipolar EGMs, because of what I mentioned here, that the activation that you measure there has two components of far field, larger ventricular versus near field, smaller from the local muscle, which is actually the focus of arrhythmia. What can happen is that the unipolar versus here, and the first signal is early. Look at the unipolar. The unipolar actually corresponds to the second signal because the ventricular mass is so much that that overwhelms the potential that you're recording from the muscle extension in the so this produces the dominant and the local small amount of mass actually produces a very shallow factor. So don't go very much to the unipolar here and bipolar system. Also have this phenomenon of differential conduction can be often seen in the tracts and can be important at all the levels of the valves also, where it's been postulated that some dead-end fibers of conduction of specialized conducting tissue are left over in the outflow tracts. And what this can result is that an arrhythmia originating in one place can actually break out in another place. And so your activation mapping may identify the origin, whereas space mapping may identify the breakthrough. And so if you have a disparity, this is something to consider, that you might have preferential conduction. An interesting finding that was reported here by Dr. Brugada's group is when you're mapping the right ventricular outflow tract with 3D mapping, and you have something on the septal surface and you don't know whether it's on the RV side or whether you have to go to the LV side and map, you can look at the isochronal area of activation. So here they have taken the area activated within the first 10 milliseconds, and two things happen if it's a left ventricle. So one is this area is larger, and if it is a left ventricular origin, actually this area becomes larger, and also this area becomes broader. That means the horizontal dimension is much larger than the vertical dimension. So if you see this kind of activation, suspect this is actually you're recording something far field happening on the left side, and you might have to go to the left side to map. When it comes to ablation, one thing note about the power to use, it has been if you see in literature, different groups use different powers in the valve cusps. What we found and what has been reported by some other groups is that that a much lower power may suffice actually for ablation here. So especially because we are close to the coronary arteries, we've used a power of 15 watts, and often 15 watts, usually in 5-10 seconds, you get cessation of PVCs and you can complete an ablation with even 30 seconds. So many of our early cases were done with this 15 watts and 30 seconds, and we did not have any long-term recurrence in these patients. Very important to be aware of that of proximity to coronaries, especially when you're ablating the left coronary cusp. It often tends to arise close to the left main origin. So always look at the distance from the coronary arteries in two views. People who use IVAS, probably that is the best way to continuously monitor. Or you have two approaches. You can do a coronary angiogram and then keep that as a roadmap and do, or you can puncture the contralateral femoral artery and have a catheter sitting in the coronary artery as you map, so that you can at any time you can see the difference and look at this in two orthogonal views. It is safe if your distance is more than 10 millimeters. Definitely do not ablate less than 5 millimeters. For right ventricular outflow tract, what can happen is that it can be difficult to differentiate whether you're above the valve or below the valve. A lot of the cases that you ablate thinking you're at a high RVOT, you might actually be above the level of the valve. So this has been shown in some cases like this, where using an intracardiac an ultrasound and ICE, they've been able to show that when you're ablating high in the RVOT, and you mark the level of the valve cusps, actually often the site is well above the cusp level, so you're ablating in the pulmonary artery. And but when you know well that you are above the level of the valves, and that when the arrhythmia is actually arising from the cusps, it helps to make this reverse U loop to access the cusp, because without this loop, it might be very difficult to map within the cusp. Also suspect cuspal origin when you are mapping very high in the outflow tract. You have a signal which is about -15, -20, and you're unable to ablate from here. So in that case, then if you just go above the cusp, form this loop and come here, signal is much better. It's about -25, and you can get successful ablation here. So something to keep in mind and suspect when you're trying to map high and ablate and you have an unsuccessful ablation. So to summarize, for effective management of these outflow tract arrhythmias which arise above the level of the valves, we have to have a good understanding of the complex anatomy of the outflow tracts, to have differentiating between right ventricular and left ventricular origin. ECG helps in terms of precordial transition, and in terms of and when there is a V3 transition, to look at R wave in V1 or V2. And electrophysiology during the EP study, Activation and distal CS can help you identify, looking at the signals in RVOT, trying to guess whether they are far field, near field, and if you're on the septal posterior RVOT, you have a failed ablation anyway to go to the left side and map. So those are things that are important. And as far as it comes to ablation arrhythmias above the valve, first thing is to be aware that these exist and to suspect them in the right situation, and then know how to map for these. Thank you.
Thank you very much, Dr. Raja Selvaraj, for a great presentation on cuspal VT, how to recognize and how to do the ablation and all. I think we'll move on to the next talk by my close friend and guide, Dr. Narsiman, and he will be talking on epicardial VT ablation, various techniques. Dr. Narsiman, please.
Thank you very much, Dr. Chandrasekhar, again, to the Tamil Nadu EP Council. I've been given the task of speaking about epicardial ablation. And over the next couple of minutes, I'll talk about this. This is the famous Dominic Jean Larrey, who defined the Larrey space. He was a surgeon working with Napoleon, and he used to drain the pericardial in patients who had been injured in war with a lot of hemopericardium. He used to use that space to selectively dissect and drain it. And then came 1996, Professor Eduardo Sosa described a percutaneous way of accessing the pericardium. And actually, one of the important work came from Mark Josephson's lab several years ago, describing that a third of patients, 30% of patients with ischemic structural heart disease have reentrant circuits in the subepicardium and not close to the endocardium. The percentage is more in other subsets like hypertrophic cardiomyopathy and dilated cardiomyopathy. So when do you reach for the epicardial surface? What is the relevant anatomy? How do we do it, and how do we prevent the complications? There are several electrocardiographic indicators of an epicardial exit site. I'm not going to go through this, but you can look up. These are very useful upfront for you to decide whether it's epicardial. Our approach has been, if it is epicardial, upfront get an epicardial access. Wherever we have tried to do transeptal, map the endocardium, and then reverse with protamine, go epicardial, there are problems. So, or bring them back next day and do it off and separate session before heparinization. I've just addressed about the relevant pericardial anatomy, which is essential for access. This is in the lateral view, sternum. The heart sits on the diaphragm, but there is a small triangular space here just above the diaphragm. Now, if you go through the diaphragm, you can still reach the space. Number one, it's very stiff and a lot of resistance will be there. More so if you are close to the fibrous tendon, which is very posterior. So try to access the pericardial space through this area. The anatomical landmark is look at the xiphoid. Just lateral to the xiphoid and the costal space is the triangular space, and you try to go through towards the left shoulder. The angulation of the needle will be more vertical if you want to reach. See, this needle has to be more vertical from the chest if you want to go posterior, or very shallow if you want to reach the anterior space. And either way, either through anterior or posterior, you have the transverse sinus, which can easily be wired, and you can come back to the contralateral space. I'll show you case examples. So this is what, if you have an anatomical landmark, you just palpate the xiphoid and go just next to the xiphoid. If it's too lateral, you run the risk of hurting the superior epigastric artery. There have been few reports of rectus sheath hematomas if you don't watch for this. So be aware of this anatomy. This is a publication which came from Noel Boyle. Again, looking at emphasizing that one of the important regions, organs where you can cause a potential injury is causing a significant hepatic injury, and it can result in a large subcapsular hematoma. Patients have been taken for hepatic surgeries following the, without inadvertently, if you put a sheath here, you won't see anything. Once you heparinize, the whole thing will become a mess. So it's very important to stay above this zone for you to ablate. Let me see if this plays. Not good at this. This is one such patient. I think this is a patient with very thin right ventricle and ARVC. We deliberately wanted to go posterior. You can see that as we go there, you can see a layering of the contrast. A thin layer, that is the space we want to. The moment the bevel of the needle of the 2E needle, it upfront you advance with a 2E needle bevel facing posteriorly or anteriorly, depending on whether you want to take an anterior approach or a posterior approach. So moment you reach that, the same, yeah, it's just the same. The moment you reach the epicardial space, it's very important to kind of wire along the free margin. Be very careful that you loop the wire very well around the heart before you advance the sheath. If you're not taking this precaution, I've had situations where people have advanced it into the RV without realizing. Sometimes when it goes all the way into pulmonary artery, it will turn around and it may just be here. Need to go into LAO and make sure that it's adequately looped in the pericardial space. This is what I mentioned, that even if the target, to get an adequate contact on the pericardial surface is important. So sometimes you may have to take a catheter, come around and loop to get adequate contact. For example, here on the, this is a VT from the inferior wall. If the catheter is, you will get an electrogram, you will get contact force will be good, but you will still have an unsuccessful ablation because the whole contact is towards the diaphragm and not close to the heart. So you need to kind of move it in a different projection and make sure that the catheter is hugging the myocardium and not against the pericardium. I'm sorry for the quality of this. For some reason, this doesn't play very well, but this is again to show another patient where we had to take an anterior approach. This doesn't play well. One of the things, you can go for a steep left lateral or steep LAO and stay very close to the sternum and have the bevel facing in such a way that the wire exits this. For patients with ARVC, patients with Brugada syndrome, this is a very useful approach. You will stay anterior to the sternum, immediately wire it with a 3-2 wire, and we prefer to take a long sheath like SL1 or a short edgeless into the pericardial space. Once in the pericardial space, you can do whatever you want in terms of, it's very easily, the catheter moves around, except in patients with prior infarction sometimes who have formed an aneurysm, there may be adhesions there. The other group of patients are inflammatory cardiomyopathies. You may have pericardial adhesions, which limit the catheter movement. You can get adequate pace map from these epicardial sites. This is one such late potential which was picked up. Please be aware, don't go by voltage map in epicardium purely, because if you see a low voltage of 0.5, but if you don't see a late potential, this may be just your catheter may be on the epicardial fat. So especially towards the base of the heart, close to the tricuspid annulus, crux, as well as in the summit regions, close to the mitral annulus, there's so much of epicardial fat, it will attenuate the bipolar voltage. So we don't strictly, if the voltage is 0.5, but you don't see fractionation, you don't see a late potential, that is generally not a good target for ablation unless it's a focal VT. Now, complications are the commonest, which has been, I mean, there's a huge list of complications. If you go through some of the German registries and others, subcapsular hematoma, coronary spasm, pseudoaneurysm, massive intra-abdominal bleeding, pericardial bleeding due to middle cardiac vein laceration, pericardial bleeding due to coronary sinus laceration, then RV abdominal fistula, pleuropericardial fistula have all been. And one of the worrying things, especially in some patients who develop a little bloody tap, is a very painful sterile pericarditis. They can occasionally have delayed bleeding when you start anticoagulation. When you ablate very inadvertently close to the coronary artery, you can coronary spasm. Rectal sheath hematomas, I did mention, liver injury, phrenic nerve injury, you need to be cognizant of. So my colleague, Dr. Muthaiya, took this task in a small, about 10 or 12 patients, where we did a pre-procedure CT to define, you can see the internal mammary artery and the superior epigastric artery, the xiphoid process here, to know how close or how wide it is. Especially here is, say, for example, you can see the position of the diaphragm, the liver, and so on and so forth. So you can sit with the radiologist and make a phantom line along the trajectory of the course of the end for the needle. So this will, for example, compared to this patient, if you want to go towards posterior space, the incident angle between the abdominal wall and the needle should be approximately 52 degrees. And the distance between this and the puncture site is approximately 4.7 centimeters. These things can be very useful in planning in a difficult ablation. While performing the epicardial puncture, it's useful to have patient's history, especially prior open cardiac surgery, or the patient had a Dressler syndrome or any of these tuberculous pericarditis. These are some of these issues. Systemic anticoagulation, better to hold before you do epicardial puncture. Even though people continue NOVAX with AFib ablation, but if you're doing pericardial puncture, I would suggest switch them over to regular heparin, stop it on the day of procedure morning, and then take it up. Use freely LAO and left lateral to, if you're planning to do project without any imaging, go anterior or posterior approaches. Preferably use long guide wires, fully encircle the cardiac borders. Never leave an epicardial introducer, introducer sheath exposed within the pericardium. Always go over the wire, and because they can easily lacerate with the cardiac movement, and injuries have been known to occur. It's very important to realize, for example, in this patient, if the patient's the same angle of entry, if you had advanced the needle during expiratory phase, you can through the colon before you hit the pericardial space. So inspiratory breath hold is extremely important. If the patient is anesthetized, you can ask the anesthetist to hold it in inspiratory breath hold when you are close to crossing the epicardial space. Cardiac pulsations are often felt as you're reaching the thing. One of the useful things sometimes is to put a little droplet of saline to start as oscillating as you enter the thoracic cage, and then start injecting the contrast. Don't inject contrast. Say, for example, if you inject contrast right from here, the whole area, you can't see anything. It's a large area of opacity, and you can't see the tip of the needle. So you try to advance the needle to the particular length where you think the diaphragm is. Either the fluid starts oscillating or you see the pulsation, you inject contrast, stain the diaphragm, and then enter this. Contrast will, as I showed you, the contrast will immediately disperse throughout the pericardium or layer around the inferior wall. Then you can, that is the place where you need to advance the wire. Again, the pre-procedural imaging tells you about where the site of puncture, angle of the needle, and the depth of puncture. What are the organs which are likely to come along the way of the needle so that they can avoid collateral damage. The skin site, you can mark it up with inspiratory. For example, this patient, now the colon has moved well in inspiratory breath hold. In this patient, we decided that the distance has to be from the xiphoid or sternal angle, this has to be about 4.5 centimeter close to the thing, and this area of puncture is already marked. Generally, for a more vertical posterior puncture, it's close to the xiphoid. As you make a more shallow puncture, it will move more to farther away because then it becomes very shallow. Very simple thing we had used in this investigation is to just take a simple we sterilize the whole apparatus and tie it. For example, we wanted the angle of entry to be about 55 degree in this person, this 52 degrees. So exactly site of puncture is marked. You can exactly enter this, and then with finer adjustment, you should be able to enter the pericardial space. Bevel of the needle is always pointed away from the cardiac border. This is important. Now, this is recently one of the VTs ablated. The target, if it's very close to the where you're getting a phrenic nerve capture, it's prudent to separate out the pericardium. So we suggest that you use a deflectable sheath and take the balloon in the deflectable sheath, and then the catheter can go in the other sheath. Because once you're in the pericardium, it's very difficult to direct the balloon. So the deflectable sheath will help you to take the balloon to the area where you want to kind of separate the phrenic nerve. It's extremely important before ablating, even if it's ARVC. For example, in a large ARVC, if you see a large RV branch, you cannot afford to cause any injury to even a small RV branch in an ARVC. That applies because they sometimes go into coronary spasm, infarct. So always anyway, we just simultaneously take a coronary angiogram before ablating these areas. Yeah, make sure that it's well away. And secondly, move the thing to RAO, LAO, and see that this catheter is hugging not the pericardial surface, but the myocardial surface. Contact force will not be able to tell you whether your contact force is on the pericardium or on the myocardium. So one of the useful things here is called as, we use the vector that is available in the J&J catheters, and the vector will tell you whether the vector is directed towards the myocardium or velocity vector or away from the myocardial surface. This is a 4-year-old child, I think Ram Prakash was there, I'm not sure. So with the incessant left atrial tachycardia, we mapped endocardially, we couldn't get a sufficient early potential. From the epicardium, we could get an early potential, which was successfully ablated. This is an appendage tachycardia. Because in olden days, when they couldn't ablate from endocardium, these patients used to go for surgery and removal of the appendage. Now, what about the role of intrapericardial fluid? This is extremely important because if you are irrigating the catheter, you are short circuiting the anode and the cathode, and you can't cause a deep lesion. So it's extremely important you drain the pericardium completely, the saline or whatever should completely come out, because with fluid, intrapericardial fluid, the lesion size is very minimal compared to when the pericardium is dry, you can cause a larger and deeper lesion. This is because of impedance drain phenomenon. Techniques to avoid phrenic, always make sure that the anesthetist, when you're giving it, do not use a paralytic agent. Do a high output pacing in the lateral wall. We generally don't inject air or saline, but we use a pericardial balloon to separate. And secondly, to avoid a pericarditis, we use colchicine, and when we come out, you use triamcinolone into the pericardium and come out. So epicardial approach is a useful adjunct to catheter ablation of VT, and reported complications occur anywhere from 6 to 12% of patients. However, with meticulous attention to details and post-procedure follow-up, we can avoid a lot of these so-called complications. And I would like to profusely thank my colleagues, Dr. Daljit and Dr. Muttaya, who helped to put this presentation. Thank you very much.
Thank you, Dr. Narasimhan, for your excellent talk on the epicardial VT ablation. You brought out nicely how to do the pericardial axis, anterior approach, and the posterior axis. And you said nearly in the ischemic heart disease, nearly 30% of the circuits are located epicardially. And I think we'll have the discussion at the end of this session. Thank you very much, Dr. Narasimhan. We'll move on to the next talk for want of time. VT in Brugada and arrhythmogenic RV cardiomyopathy by Dr. Ajit Thatchell. Dr. Ajit, please.
Good afternoon, and thank you for the invitation to talk in the Tamil Nadu EP Council, especially to Dr. Jayashankar. My task is to talk on the management of ventricular arrhythmia in Brugada syndrome and ARVC. I'll start with Brugada syndrome. Brugada syndrome was initially defined as this type 1 ECG pattern of Brugada, which meant a 2 millimeter J point elevation in 2 out of 3 leads from V1 to V3 without an STT angle. This was the initial definition. Now there are 3 types of Brugada ECGs described. The type 1 is more than 2 millimeter ST elevation in more than 2 leads out of V1 to V3 with a monophasic T and a terminal T wave inversion. The type 2 is a saddleback T. Type 3 is either type 1 or type 2 pattern, but the ST elevation is less than 2 mm. Only the type 1 is considered diagnostic, and only type 1 carries a risk for arrhythmia. And these patterns are best seen in the 2nd, 3rd, and 4th right and left intercostal space, meaning 1 space and 2 spaces above where V1 and V2 would be kept. So these are the 3 types, rather. The type 1, cowed elevation, the type 2 and the type 3 saddleback elevation, the type 3 having less than 2 mm ST elevation. It's important to distinguish this from right bundle branch block, where the angle between the STT segment angle is preserved, whereas in Brugada, that angle is not preserved. So the original definition was this, the 2013 definition. That is what I just described, 2 mm ST elevation in 2 leads. They removed V3 later because it's hardly ever seen in V3. So 2 mm ST elevation in at least 1 lead among V1 and V2 in the 2nd, 3rd, or 4th intercostal space, spontaneously or after IV provocative drug test. Subsequently, some of the experts felt that this definition needed some modification. So they came up with something called a Shanghai score, where the spontaneous type 1 Brugada pattern at nominal or high leads still diagnosed probable or definite Brugada syndrome because it had a score of 3.5. But a fever-induced type 1 pattern or a pattern which converted on provocative testing was not diagnostic. It was given a score of only 2 because this comes with the knowledge that converting type 2 to type 1 doesn't really have the same connotation as having a spontaneous type 1. There are also other things that are part of this score. The unexplained cardiac arrest, nocturnal agonal respiration, suspected arrhythmic syncope. There are a large number of things. But basically, it's a score. So the next thing that we need to understand is that this type 1 pattern can be intermittent. So this is the pattern on one day. This is the pattern of the same patient the next day. So this patient has a less risk of ventricular arrhythmia compared to a spontaneous persistent type 1 pattern. So a spontaneous or a drug-induced change can occur from one type to another type. An ECG 1 space higher can change type 2 or 3 to type 1. Fever can change type 2 or 3 to type 1. And sodium channel blockers like flecainide, ajmelin, or procainamide, and some other drugs can induce type 1 in susceptible individuals. So where does this leave us? This means that any patient with a Brugada pattern must treat the fever promptly. Also, there are several drugs which precipitate ventricular fibrillation in Brugada syndrome, and there's an extensive list of these drugs available at this website. All patients should avoid such drugs. So what causes Brugada syndrome? Before going into treatment, let me just briefly tell what causes. Some abnormalities in the right ventricular outflow tract causes. What are these abnormalities? The most commonly accepted theory is this. Now we look at these cells, you can see that this particular cell has a long action potential and this particular cell has a short action potential. What is the net effect? At this point of time, there is a current going from this action potential to this action potential. That is, there is a cell-to-cell current. So in patients with Brugada syndrome, different cells in the RVOT, epicardium, and endocardium have different shapes and different durations of the action potential, with the net result that at one point of time, when one cell is positive, the adjacent cell is negative. So there is a cell-to-cell re-entry. And this is the most commonly accepted theory in Brugada syndrome. There are some drugs which make this worse. Now look at this example. This is the normal cell. This is the endocardial cell. This is the epicardial cell. Look at this particular notch in the epicardial cell. Now, when we give a drug called terfenadine, that increases this notch only in the epicardium, not in the endocardium. Why does it increase this notch? Because it blocks a current called the transient outward channel, the ITO channel, the transient outward current channel. And that is blocked only in the epicardium. And that makes the phase 2 of the epicardium negative. whereas the phase 2 of the endocardium remains positive. So there is a re-entry happening between the epicardium and the endocardium at this point. Now, if you give an even higher dose of this drug, the epicardial action potential becomes shorter. So at this point, there is a positive endocardial action potential and the epicardium is near negative, causing a re-entry between the epicardium and the endocardium, which means some drugs can make it worse. Some drugs can make it better. Drugs like quinidine can block the transient outward channel in the epicardium, the ITO potassium channel, and replace this notch, get this notch back, get rid of this notch, and these drugs can be effective in Brugada syndrome. Vagotonia causes more of this notch, so does flecainide, whereas sympathetic stimulation causes less of this notch, which means that if a patient has a VF storm and Brugada pattern, the best drug to do is to give him sympathetic stimulation. Isoprelin infusion is the best way to control a VF storm in Brugada syndrome, and which also means that a lot of events happen at night. Approximately 1% of people with spontaneous type 1 pattern carry a risk of sudden death. Now, this is a problem because only 1% have a problem. 99% are fine. The problem is the first manifestation is usually sudden death, and which is usually due to VF or rarely rapid VT. And VF and sudden death usually occur during vagotonia, typically at night. So nocturnal sudden death and nocturnal agonal respiration are typical. The only proven therapy is an ICD. Drugs may be effective, but it's not sure which patient drug will be effective. And the only role of drug is to reduce ICD shocks, and that too only quinidine. Plus minus value. Silestazole and maybe quinine may be helpful in some reports. RFA in the abnormal part of the RVOT is an option. So this means we need to try and find out that one person who's going to die and give an ICD to that one person. How do we do it? Can we use this Shanghai score? The originators of the score say so. There's another score called the Sierra score, which use some other variables. The originator of this score says that, okay, this score is also good. If your Sierra score is more than 2, it means there is a fairly high risk of sudden death at 1 year, 5 years, and 10 years. But then again, some of the investigators compared both the Shanghai score and the Sierra score and said that in asymptomatic people, neither score is of great predictive value. So where does that leave us? Well, we still don't know. So yet another score came called the Brugada risk score. So these are all the components of the score. I will not go into the individual components, except to summarize that this score also finally found out that the most important predictors are a spontaneous type 1 Brugada ECG and syncope, and some use was found in an early repolarization pattern in the peripheral leads in addition to the spontaneous type 1 pattern. But basically, it comes down to a spontaneous type 1 pattern and a syncope. What about the role of EP study? Now, this is where I want you to look at. In patients with spontaneous type 1 ECG pattern, if you induce a VF on EP study, there's a 1.7% risk. But the important thing is, even if you do not induce a VF, a negative EP study still has a 0.8% yearly risk. So a negative EP study doesn't really, say that you're not going to get an arrhythmia. And if you don't have a spontaneous pattern, if you only have a drug-induced pattern, whatever the result of EP study, it's not really going to contribute. So this is how I'd summarize that. So no syncope, spontaneous type 1 ECG, it's a usual problem that we face. Do we put ICD? What I do is I ask my patient, will a change in yearly mortality from 0.8% to 1.7% change your outlook? Most of the patients will say, no, I'm not going to take a decision based on that. If my first degree relative has died of Brugada, I would rather have an ICD. And some others say, no, I can't afford it. I don't want an ICD, whether it's 0.8 or 1.7%. So now look at this. This is a history which is typical of vasovagal syncope. I'm not going to read through the history. This patient has this particular ECG, spontaneous type 1 Brugada. Do you put an ICD? What is the next line of management? Well, the syncope is not suggestive of aborted ventricular fibrillation. The syncope is suggestive of vasovagal syncope. So take the history of syncope in detail, because that is what is going to tell us whether to suggest an ICD or not. What about epicardial ablation for Brugada syndrome? So here's the ablation catheter in the epicardium. And we get this small discrete area of low voltage in the epicardium, the red area that has this long fragmented potentials and ablating here to get rid of these potentials. Well, right from the first description from Nadimani in 2012 has shown excellent results, but all of these descriptions are for patients with VF storm. Dr. Narasimhan's group, when I was working there, had the same results. And I've personally done 4 patients. All of them had excellent results in VF storm. Now, what about extending RFA to patients who do not have VF storm? Right now, we do not have data. Maybe yes, maybe no, we don't know. So the suggested management is, if somebody has electrical storm, isoproterenol. If somebody has prior cardiac arrest or sustained VT, ICD. If somebody has seizure or syncope suggestive of an aborted sudden death, well, probably ICD. Everything else, we are not sure what to do. That's basically where it stands. So my conclusions are, management of asymptomatic type 1 is unclear, except avoid precipitating drugs and treat fever promptly. Detailed utility discussion of the utility of EP study. Will a change in yearly mortality from 0.8% to 1.7% change your outcome? If so, do an EP study. RFA seems to have good results in VF storm. In other patients, should we do RFA? Not sure. The best candidate for RFA is unclear. Frequent ICD shocks, definitely RFA. Infrequent ICD shocks, quinidine. Well, what about quinine silestazole? Not sure. Quinidine, by the way, is not available in India. Now, management of ARVC. ARVC or ARVD, or right now people favor the term arrhythmogenic cardiomyopathy because actually it also involves left ventricle in a reasonable number of patients. It's a fairly common disease affecting the cardiac desmosome, usually affecting the RV, starting from the epicardium and spreading to the endocardium. It affects the desmosome. Now, what is a desmosome? The desmosome is a thing that binds two cardiac cells together at the region of the intercalated disc. The desmosome has multiple proteins here. ARVC is basically a disease which affects these proteins. And affecting these proteins not only affects cell-to-cell cohesion, it also affects cell-to-cell electrical signaling and causes arrhythmias. It usually manifests as exercise-induced VT or VF, unlike Brugada, and sudden death, which is 0.5 to 3.5% per year. And as you might imagine, PVCs, NSVT, and palpitation and syncope suggestive of arrhythmia. And in some patients, it will progress to right ventricular or left ventricular dysfunction. Now, the difference here, unlike Brugada, is about 65% have an identifiable mutation and about 50% of the mutations are in the desmosome. And family screening is recommended for first-degree relatives or probants with identified mutations, unlike Brugada. Now, this is the diagnostic criteria for ARVC. I won't even go into it. It's an extensive diagnostic criteria. If you want to look it up, there's the reference there. What are the treatment options? Avoidance of strenuous exercise in all affected patients and gene-positive normal patients. That is the role of genotyping in ARVC, unlike in Brugada. Antiarrhythmic drugs, amiodarone and beta blocker alone or in combination or Sortlot are useful. For obviously all patients with BT, maybe with NSVT. RFA usually will require endocardial plus epicardial for all patients with BT or ICD shocks. Now, ICD is the only therapy that will reduce mortality, not drugs. So who gets an ICD? There are multiple high-risk features proposed. There is no real consensus, but there is a task force recommendation saying that people with aborted sudden death due to fast ventricular arrhythmia, sustained VT, severe dysfunction of the RV or LV must get an ICD. If there are more than one major risk factors or out of syncope, NSVT, or moderate dysfunction of the RV or the LV, it is preferable to put an ICD. More than one minor risk factors among the classification that I showed above, may consider ICD. Healthy gene carriers, no risk factors, no ICD. There is an emerging role of extensive RFA in epicardial and endocardial RFA in selected patients with hemodynamically tolerated monomorphic VT who do not develop left ventricular or right ventricular dysfunction. So I'll stop with that and open for questions. Thank you.
Thank you very much, Dr. Thatchell, for your nice presentation on VT in Brugada and ARVC. I think we'll have the discussion at the end of the session. We'll, for want of time, we'll move on to the next talk by Dr. Haigriv Rao on management of VT storm. Dr. Haigriv, please.
In the very onset, I thank Dr. Jayashankar and the EP team of Tamil Nadu State for giving me this opportunity to talk. VT storm is one of the most catastrophic clinical syndromes that can be seen ever by the cardiologist. It is a very, very stressful situation, both for the patient's families as well as for the cardiologist treating. Basically, it is defined as a 3 or more distinct episodes of ventricular tachycardia, ventricular fibrillation in 24 hours, requiring intervention of a defibrillator. The incidence is 10 to 28%, and it's a life-threatening emergency. The important thing is the mortality is very high, 60 to 70%. And even those who survive, there's a twofold risk of all-cause mortality, particularly in the first 3 months. And that is why it's clinically very relevant. Now, there are different substrates which can cause VT storm. Basically, anything which can cause VT can cause a VT storm. Ischemic cardiomyopathy, non-ischemic cardiomyopathy, ischemic brugada, hypertrophic are all the causes which can cause. Many of the substrates typically are involve a scar or a re-entry mechanism around the scar, and because that's the most common, in my talk I'm going to deal mostly with this substrate only. Now, if you look at the scar VT mechanism, it is very, very well elucidated in the literature. There is a scar and there is an outer loop of circuit and inner loop, and there is an isthmus, which is very important. And this isthmus is the area of slow conducting zone, and this is responsible for the anchoring of the VT, and ablation of this area is which terminates and probably causes freedom from VT. So this is the basic circuit which is there in all VTs related to scar, and this will also be similarly there in patients who have a storm. Now you can see that the VT in this 3D map, what you can see on the left side of the panel, you can see it is going around the scar, and the one which is marked in the white is the area of slow conduction and which is responsible for the anchoring of the VT. Now the problem with patients who present with VT storm is they have multiple spontaneous VTs like this, and you can see that the VTs differ from each other. There is not a single VT. The morphology, if you look at the morphology on the panel A and panel B, it is slightly different. In a sense, you can see the V2 is positive, negative, and it is positive here. And similarly, look at C, it's predominantly negative in lead 1 and lead 2, which is not the case in panel A and B. And the lead 3. So this is a patient who present like this with different VTs, one changing into another. This is the biggest challenge of mapping these VTs. The second challenge is they're unstable. The patient goes into VT and the blood pressure drops and you shock it. So it's not easy to map these VTs. So, and not only that, one VT morphology changes into another VT morphology among the 4. So these are the challenges in mapping a VT storm in patients who develop recurrent VT. Now, the other way the patients present is patients who are already implanted ICDs, they present with multiple shocks. This is a patient who had an ICD implanted post bypass surgery for VT. It's ICD implanted for secondary prevention. And about a year later, this gentleman develops multiple VT shocks, appropriate shocks from this ICD. And by the time he reaches hospital, he has, as you can see, many episodes of appropriate VT shocks. So this is another presentation, which is also very, very psychologically depressing for the patient who has an ICD to get multiple shocks. So this is a very important topic also, apart from the VT itself. The management protocol for VT storm in our institution is typically, so if you have a recurrent ICD or VTs or ICD shocks, we interrogate the device and check if the shocks are appropriate. Now, the important thing is that these patients, the ICDs are turned off, the therapies. The biggest reason for this, number one, is that repeated shocks depress the LV function, and these also cause a lot of turmoil and they worsen the mortality. And needless to say, repeated shocks deplete the battery and the ICD goes off. The Next thing is they are connected to the external defibrillator, and whenever VTs come there, this is a standard approach. Now, then do a workup for the reversible causes, particularly biochemistry, thyroid, or if the patient had a bypass surgery recently, or if ischemia is suspected, if the CAG is indicated, we do a CAG. Sometimes it certainly helps. So these are all done to see if any reversible causes are there. They're very, very important, these reversible causes, because sometimes you just correct them and you can get the patient out of the VT storm and discharge without doing any more procedures. But let us say the patient doesn't have any reversible causes and he keeps on getting shocks, then we maximize the medical management, beta blockers and AAD. Now, an important point at this point is that all the patients get an elective mechanical ventilation. This is a very, very important thing. Now, a patient who has multiple shocks is himself very distressed by the shocks. So the first thing is to sedate him, knock him out, and make sure that he doesn't suffer the pain. This is done by mechanical ventilation. The second thing is when you mechanically ventilate the patients, you decrease the sympathetic drive, and that itself removes the fuel for the VT storm. So many patients, by putting on mechanical ventilator and sedating, knocking out itself, the VT storm becomes a little more controllable, or the VT's frequency comes down. Some of the patients may require IABP for a transient time to support, because many of the patients have a very severe LO dysfunction, which is further worsened by the shock. So they are in hypotensive in shock. So that is another thing. And once this is done, we have got two options. One is the 3D mapping in ablation and bilateral sympathetic ganglionectomy. Now, as you can see, there are three important things that we already seen in this protocol, which do the same thing, that is decreasing the sympathetic drive. Sympathetic nervous system has a very important role to play in the perpetuation of VT storm. The maximal beta blockers are the first arms to target this. Now, the second thing is a mechanical ventilation, which decreases the sympathetic drive. And the third is a bilateral sympathetic ganglionectomy, which also does the same thing as these two. Now, patients, bilateral sympathetic ganglionectomy is where you resect the distal half of the stellate ganglion and the thoracic T1 to T4 ganglia. And this is sent for a histological examination to see that the surgeon has resected the ganglion. Now, this surgical procedure, and once it is proven that it is there, and the patient is sent back to the ICU. Now, this itself can reduce the VT storm burden. And typically, we advocate that it's bilaterally done. Unilateral, in initial days, people used to do unilateral, and if it VT recurs, like bilateral. But now, literature-wise, we are all wise. We realize that bilateral stellate ganglionectomy is the therapy that is to be done if you want a. Now, as you can see, there are nerves which can go into other blood vessels, and there are some reports of doing a renal denervation also for sympathetic storm, but these are not a part of protocol. This is a standard protocol. Now, the next most important thing is a mapping and of the 3 VTs. Now, some of the patients who have a scar and typically the ischemic cardiomyopathies, we do a conventional mapping, and entrainment is not possible because many of the patients have a multiple VTs, different morphologies, going from one morphology to other. They're hypotensive and all this. So we have evolved for VT storm a substrate-based ablation. Now, Jays et al. Long back in 2012 in Circulation described the abnormal ventricular activation as being the perpetuator of VTs. So they described that after the QRS is deflection is seen, there are small potentials at the end of the QRS, and these potentials are the ones which are well beyond the QRS for late potentials, fragmented. You can see these highly fragmented potentials which are beyond the QRS, and these perpetuate the VTs and the scars. So they are very important targets for ablation. Now, second thing is sometimes you don't see any electrograms like you can see in the first part of the left ventricular electrogram here, and then you pace the right ventricle and you give an extra, and you can see what looks to be a single signal. By pacing, it separates out, and then you can see a late potential. So these are the hidden late potentials. Like the previous slide where I showed the late potentials, these are the very, very important important in the pathogenesis and the perpetuation of VT. Now, our strategy of substrate ablation has always been that we do in sinus rhythm. Now, this is one patient where you can see, one I would like to show, that you can see that this is a very dense map that we do in sinus rhythm. The patient, you can see this, we generally map in our series about 392 to even 1017 points, a mean of 631 ablation points that we have carefully mapped. And we do a high density mapping in and around the scar and a low density mapping in the faraway areas. We generally keep our bandwidth as 0.5 to 1.5 as a borderline, and less than 0.5 we take it as the scar. And we map extensively, and then we look for the following potentials. We look for delayed late potentials, as I've described with J. et al. You can see the QRS. Beyond the QRS, you can see a late potential. Then you can see the fragmented or a fractionated, highly fractionated, the continuous electrical activity, which replaces the QRS as a single potential. Then we have the double potentials, and then sometimes you have very late fragmented potential. You can see that this is very late and it's also fragmented. The actual QRS is practically non-existent, but the late potential is very much there. So these are the targets of ablation. So we carefully map in and around the scar or within the scar to look for these kind of potentials and ablate them point by point, as many as we can. And you can see this is a particular patient where the QRS and is a very, very large late potential. You can see that you can see the map on the bipolar showing the QRS followed by a very late. Sometimes the late potentials are so big and they are pathologically very important because you ablate them. So in our experience, we found that whenever we find late potentials in a large number and we ablate them, generally the success is very high. So we had published this data in about 3 years back. We have done many more cases after that, but this is a paper publication. So we had 16 patients who had recurrent VT in 6 and ICD shocks in 10. And these patients worked for reversible function. And one patient had thyrotoxicosis. We didn't have to do anything, just take care of the thyroid, and the patient became well. Post-CABG patients had 2 who had a graft which was not grafted, or the graft had closed. So they underwent an immediate angioplasty immediately, and this took care of the polymorphic VTs. And other patients, apart from these patients who were reversible factors, rest of the patients, we optimize the beta blockers. Now, optimized piece we give, there is no dose. We give the beta blockers as much the patient can tolerate, even 100 milligram thrice daily through the Riles tube, to make sure that the patient gets a heart rate of about 50-55. That is our target. The lower the heart rate, the better. And all the patients had mechanical ventilation. 2 of them had IVP. 12 patients had electroneurovehicle mapping, and sympathectomy was done in 2. 14 patients survived to discharge with this protocol, and 14 alive at a follow-up of more than 1 year. I mean, now it's almost 3 years, and VT recurrence in 2. But these were simple non-sustained VTs, and on device interrogation, well managed with medications. So you can see that at the mean follow-up of 30 months, the patients were free of VT and free of electrical storm, and the long-term survival and VT-free survival of 86%. You can see this is a very, very gratifying thing when we interrogate these patients and we get 0, 0, 0 on the VT and VF. So this is what we repeatedly see. So patients who are metoprolol up to 200 milligrams, and an amiodarone we give for 1 month, and then after 1 month we generally stop the amiodarone. Patient, most of them have LV dysfunction, so anyway the metoprolol is good for them, so they will be on metoprolol indefinitely. So we published this paper in 2017. That is the data that I'm showing, and this is and we are continuing to follow this protocol. Now, in the last few months, we had developed another technique, percutaneous stellate ganglion ablation. Now, patients with who require stellate ganglionectomy, the problem is it is a surgical procedure. So it has the morbidity of surgery, and it is expensive too. And also the patient has technical challenges like a single lung ventilation. So with the help of our anesthesia team and the pain specialist, we developed this percutaneous stellate ganglion ablation, and where we had about 4 patients with 1 patient with hypertrophic cardiomyopathy, 2 patients with ischemic cardiomyopathy, and 1 with NICM at 50 to 60 years of age, and all of them had ICD either before or after the procedure. Now, the reason why we took these patients for this purpose and with in preference to ablation is because one patient had a LV thrombus, the second patient had a polymorphic VT VF, which we thought was not amenable for ablation. The third patient had a financial issues and also a cerebrovascular accident recently, and with a thrombus, we did not feel it was very comfortable. And the last patient had a small mid myocardial septal scar, and we thought it was good ejection fraction, but we thought it was not an easy scar to ablate. The success rates of such scars are generally low. So for these reasons, we thought we would do this ablation. Here, what we do is patient has at 2 levels, at C7 level in the supine position and T1 level in the prone position. So what they do is they puncture with a needle and they pass the radio frequency ablation, and you can see that the needle on a fluoroscopy is seen by this point at the junction of C7 body and transverse process, and here, and through this, the fluoroscopic position of the needle, and then through this, the radio frequency ablation is applied in the standard way. So with this, we realized all the 4 patients were, we applied this, and 2 patients had non-sustained VT before discharge. The rest of the patients didn't have anything. The follow-up duration ranges from 17 days as on today to 189 days, and none of them have VT, and all of them had VT storms, recurrent VTs, and we could get out of this. So we're just trying out this procedure as an alternative to stellate ganglionectomy in those patients in whom ablation is not possible. So in conclusion, VT storm is a life-threatening cardiac emergency with high mortality. Having and following a systematic protocol in the hospital is the key to improved outcomes, as I have shown the protocol that we follow in our institution. Radiofrequency ablation by 3D mapping and ablating all the abnormal electrograms forms the mainstay of therapy in many patients who have scars. Sympathetic degeneration is a useful tool in some of the cases. In some cases, we may be requiring now to do a ablation of this stellate ganglion in preference to the surgical denervation. Thank you very much for your patience.
Thank you very much, Dr. Agri Rao, for your excellent talk on management of VT storm. You brought about various aspects of management, like mechanical ventilation is very important, and the general anesthesia, then medical, maximizing the beta blocker dosage. And also you talked about the catheter ablation, the role of catheter ablation in VT storm. Then you talked about the bilateral ganglionectomy, sympathetic ganglionectomy. And lastly, you talked about percutaneous stellate ganglion block, and a very nice presentation. And all the topics are excellent, and it needs a lot of discussion, but want of time, I think we'll conclude the session here. And I'll request Dr. Jaishankar to say the last word before concluding, and to introduce the next topic and the panelists to moderate that session. Thank you. Thank you very much.